Well, thank you for joining the Minnesota Acute Coronary Syndrome, non-ST and ST Elevation Myocardial Infarction Consensus-Based Guideline Conference Call. All participants will be in a listen-only mode until the end of the presentation of today's call. Questions will be taken at the end. You may press star and 1 to ask a question. Today's conference is being recorded. If you have any objections, you may disconnect at this time. Now I'll turn the meeting over to your host, Mindy Cook. You may proceed.
Welcome to our webinar today on the Minnesota Acute Coronary Syndrome Guideline. We have 3 guest speakers with us today, including James Peacock. He's an epidemiologic supervisor at the Cardiovascular Health Unit in the Minnesota Department of Health. Our objectives for today are to describe the key components and scientific rationale supporting the Minnesota Chest Pain Acute Coronary Syndrome non-STEMI and STEMI consensus-based guideline. We'll use guidelines to apply best practices and our case reviews to illustrate how those can relate to actual patient care. An update from the Minnesota Department of Health on the cardiac system of care related to STEMI receiving sub-designation and data reporting, and demonstrate the AMI regional data reporting through the Get With The Guidelines CAD registry. Guest presenters today are Dr. Scott Mikesell. He is an interventional cardiologist at St. Luke's in Duluth, Minnesota. And then Jared Mulvane, who is a cardiovascular clinical pharmacist and STEMI program manager at Essentia Heart and Vascular in Duluth, Minnesota as well. Our mission systems of care are by the American Heart Association that stream across a geographical region and regionalizes STEMI systems of care. And we define that system as the geographical state of Minnesota, and we've come together with this work group by leaders from the health systems across Minnesota to develop this tool to enhance and streamline care for this population. And welcome Richard Mulvane, our first presenter, who will go over a brief history of the Minnesota STEMI ACS work group and risk chest pain section of this guideline. I'll turn things over to you.
Great, Mindy. And hello and welcome again to everybody. Thank you for joining us. I'm Richard Mulvane. I'm a clinical pharmacist up in Duluth. And I'm going to be sharing with you a little history of how we got here today and how these things are created, as well as covering a new plan for how we take care of low-risk chest pain. So hopefully you can see on the screen here a buddy of mine who actually had a STEMI and had 24 shocks afterwards, and we were able to pull him through. It's just a good reminder to me of why we do what we do. When we hustle and we do standardized care, guys like this back out in their boat and back to their life, and it just means so much. So history on the work group, if you will, we're very grateful back in 2007 when Dr. Tim Henry and others, including Ganesh Ravidran, really said, let's get together as a state and can we do something together? And a lot of great work was done, some meetings, and really over the few years we got close, but things kind of stalled out. In 2013, we were fortunate enough to get the Mission Lifeline and the grant here, and a lot of key players there, very much thanks to Mindy and Gary and Michelle and others. There's so many people to thank. But we were able to get it done and got a statewide STEMI guide, if you will, for both the hospitals and EMS. And as the grant ran out in 2016, we really want to keep this work group kind of together. It's handed over to the Minnesota Department of Health. And so we've been working this last year or so on, well, what else can we make a non-STEMI guideline as well as possibly a low-risk guideline? That's what we're talking about here today. So our goals here are to, basically share with you and offer a way to standardize care across systems that wish to do this. So, as we know, standardizing care is very, very helpful. And what we're doing is kind of morphing into a toolkit here, which would be essentially in 3 buckets. So we've already kind of gotten STEM taken care of. Then we'll think about what do we do with non-STEMIs, and then a chest pain plan for those that aren't rolling in for MI yet. Our toolkit It's a 15-page document. It is available on the Minnesota American Heart website, and it will be available, I believe, on the Minnesota Department of Health soon when we figure out some formatting. Again, I'm going to focus on one of the three important things here, which is the chest pain piece. And so we know when someone has MI that a troponin, well, a leak, but a rise, and it actually happens over probably several days. But we want to catch people at the beginning of that, if possible. That's why we sometimes do serial troponins, because if we miss it on the first one, hopefully we'll catch it on the second or possibly third, if that's the scenario. And looking at the past, if you're doing biomarkers, looking at troponins, but not necessarily using any risk tools like TIMI or heart score, the risk is just too high at those people who are having MIs down the road within 30 days. And so if you use a clinical decision tool like the heart score, you can see that on top of the troponins can really reduce the risk of someone having a MI. And it would be real nice if we could get that less than 1%, and we believe that we're going to be able to do this with the heart score. This is from the 2015 CPR ECC guidelines, and basically endorsing on the bottom there the use of the heart score. I apologize, I have a lot of slides here that I'm not going to read everything, but I wanted to include these as a reference too if you want to know where some of this stuff is coming from. Just a little bit more here. Why use heart score versus TIMI? Well, TIMI actually has poor predictive power. It doesn't use history or clinical judgment, and heart score actually outperforms the score in this scenario. So let's think about what other guidelines say. In 2010, AHA came out with this statement basically saying with folks that show up with chest pain and we can't figure out what's going on, I'm paraphrasing, but you probably should do a stress test on these people. So we've been doing tons and tons of stress tests for a long time. And this is just a complicated graphic from those guidelines, but I added this green box. There really isn't an option. Well, what about these really super low-risk people? Can we actually send them home? And that's what we're talking about today is what can we do to take care of these lower-risk people, as well as acknowledging that a lot of times stress testing is not readily available, and we try to send them home maybe and bring them back in a patient setting within 72 hours, but a lot of these may not even be necessary. So in the future, we may back off on this need for stress testing. The ER physicians, are very concerned. They don't want to send someone home that's going to have a greater than 2% risk of having an MI in the next 30 days. They want to miss that. But a lot of those statistics were based on old data. In 1993, remember, our troponin testing has gotten much more sensitive. So really, some of the things that have historically scared us really aren't as valid today. This is also from ECC CPR guidelines from 2015, basically opening the door to say if you do some serial troponins and you use a clinical scoring system, then we might be able to have some success. So I mentioned these differences between the TIMI and heart score, but once again, the heart score is a bit better predictive value and does incorporate history and clinical judgment by the ED physician. And so by doing this, we're hoping that we can reduce costs, need for hospital resources, unnecessary admissions, and ultimately a better patient experience would be great. So this is just a history of where that heart score came from in the Netherlands back in 2008, the ECG age, risk factors, troponin, and the point system associated with that. And back then, the predictive value was still pretty good, but not fantastic. You're low risk. They still have 2.5% risk of an MI, which is not considered, acceptable for a lot of our ER physicians today. They like to get it much less than that. Other publication here just demonstrates also incorporating a shared decision tool, which we know is very important for care in many areas, and it certainly applies to chest pain, potential heart attack care. And from Heston colleagues, this is an example of the chest pain decision tool that they were using and had published this. And by using this, they actually were able to reduce the amount of stress testing that was done. They were able to reduce the amount of people who were in the OBS unit or admissions and basically send them home. Also coordinated better follow-up. So that was a success. And then the slide has some links if you're interested in watching the YouTube video. This is great. This is from ASAP, College of Emergency Physicians. these won the they won an award for this work that they did at the University of Michigan. Basically, they did the same concept using a shared decision tool, showing to the patient, this is what we think right now, and what your risk is for an MI. And then also created a moderate risk, so if you were not low risk, now you're up to more of a 13% risk. And then the risk group is more like a 50% risk. So this would be almost a tool to argue someone who wants to leave AMA, hey, we don't want to let you go. In fact, this person probably needs to be run for ACS and admitted. And they looked at performance as well. They were able to reduce observation and increase the amount of people who were discharged. So that's Michigan. Now, in the University of Maryland also kind of built upon this, but essentially the similar philosophy. But if you notice at the bottom bullet here, they wanted something that was medically sensible and defensible, and that's exactly what the HEART score gives us, as well as this consensus guideline that we're trying to share with institutions here in Minnesota. And this is, again, their rationale when they were developing their tool and their plan. And we implemented this, again, serial troponin, a shared decision tool, HEART score type of, they were able to have a risk reduction in patients and OBS, and the physicians were very happy with the plan. And again, you're getting the ECG on arrival. I'll show you, we're basically going to adopt the same plan here for Minnesota. You get the HEART score after the first troponin, but you're kind of taking them up and getting ready for when you get that second troponin and hoping that it's negative. If they're a really low HEART score, they'll have a really good conversation about, or an argument to send a lot of these people home. And this is an example of the tool that they use, very, very similar to the other ones that I've just shown. Again, some of these slides here, I'm not going to read them. They're here for your reference. But just to let you know that we didn't just make this up. This has been tried in very successful other places. So boiling it down into the Minnesota plan, if you will, again, the key ingredients or the secret sauce here is to have the HEART score as well as the shared decision-making tool. Using this, again, we're hoping to really reduce a lot of unnecessary resources and costs, and like I said before, a better patient experience. And we have a little bit over here, I apologize, but there's some more validation of the HEART score. So if you do this shared decision tool and the HEART score, and you repeat a troponin, like hour 2 to hour 3, somewhere there, you're going to now get that 30-day MACE risk to less than 0.6%, which most emergency room physicians find very acceptable compared to the old numbers back in 2008, which was more like a 2.5% risk. So we weren't as happy with that. So this is very reassuring for us, and it's also possible because of the high sensitive troponin assays. So if we can just take a look here, our plan, if you will, or guideline, protocol, whatever we want to call it, probably more of a guideline, is that when someone walks in the door of an emergency room in a Minnesota hospital, obviously we want to get a stat ECG, 12 lead, and a troponin. And if ECG is showing ischemia or STEMI, well, we're done. Then now they are STEMI alert, or if it's showing ischemia, then we move that. But if it's not, we wait for that first troponin result. Sometimes it's within that first hour or so. And of course, if symptoms change, repeat the ECG, because STEMIs can brew up right before our very eyes, and we would be done. But let's assume that the ECGs were negative, and we get first troponin back, and it is negative. And so I'm going to advance to the bottom half of our thing, and it's a little complicated here, but we're going to head that we've already got one negative troponin and a negative ECG, and we've calculated a HEART score. So look on the left side there's kind of the green, yellow, red. And then there, if you on the green, you look right, you kind of read it across from there. That's kind of the low-risk zone, if you will, in the green. We'd like to use the low-risk shared decision-making tool that we're about to show you. And at that point, after one troponin and a HEART score is low, they're in about a 7% range of a major adverse event within 4 to 6 weeks. And some of these patients may even want to leave at that point, and that's really up to the ER physician. We can't, it's their judgment. But what we're encouraging them is to stay for that second troponin. In negative, it can feel our way back if the patient is comfortable with that, and that risk is probably, again, probably 0.6% or less, those folks can probably go home with no stress testing, but certainly we would like to encourage follow-up with the provider. In the middle of the scale, if you will, or the flow chart, starting with the yellow zone. Now, these are people with a heart score of 4 to 6, or if their troponin was, and their troponin was negative. These are a little higher risk folks, probably more like a 13% risk. We don't want to send them home. These are the ones that we do want to do serial troponins on, and most likely they will probably need a stress test. And then on the bottom here in the red zone, if you will, the high heart score, well, those are pretty much rule in for ACS non-STEMI anyway, because these people are at a 50% risk, and we don't want them to go home. So anyway, I hope that makes sense. I know I went through it fast, but again, this is available for reference. And after this seminar or webinar, I also would welcome questions from places that are interested in clarifying or how to implement this. And so now here is an example of the shared decision tool that we are using, almost the same one up here in Duluth, and it was approved by our work group, if you will, and it's the same idea. The patient is told that, you know, you're based on people like you. We don't think you're having a heart attack at this time, but we would recommend maybe another troponin. But if that is negative, your risk is going to be less than 1%. And plan ahead to get you home. And that's the whole value of this. If you're planning ahead, rather than waiting for that second troponin, then reacting to it like an hour later, now 2 or 3 hours more have gone by. You want to tee them up quicker, and then you'll be able to get much faster throughput through the emergency rooms. So that's the low risk score. I'm going to advance to the moderate risk now. These are the folks where their heart score is in that 4 to 6 range, and these are the folks that we really don't want to let them go home. And this shared tool can help that conversation with the patient. And then finally, here's the high risk score, and these again are the people that we absolutely don't want to go home, and we probably most of these will rule in for acute coronary syndrome, and we need to keep them. And then this slide here just kind of shows all three green, yellow, red plan kind of boiled into one piece of paper here. I know it's kind of crowded, but it's a good overview of what the flow chart plan really is. And then on the bottom, it has all of the aspects of the heart score if they wanted to do it manually. I'm going to advance to this next. Oh, okay. I'll just make a comment here that in our system, we have the EPIC medical record, and it's easy to put the heart score in EPIC as well as a link to these shared decision tools, and that's what we're doing here in the system. And if anyone needs help with that, they're also welcome to contact me. And finally, I felt this was very important piece of our tool. It's struggle with standardizing who really needs an ECG, because a lot of people think they know, but they have maybe different values or ideas of who really needs an ECG. And this was built, this tool here is built on a publication that looked at over 3.5 million ER visits and at age 6, and basically who went on to actually have ischemia or acute coronary syndrome. As you can see, as the age goes up, the threshold kind of goes down for who needs an ECG. So, example, if you're over 80 years old, pretty much anything from navel to nose or above, folks will need an ECG. But if they're, 30 years old, and obviously they're having chest pain, we should get an ECG. But if they're coming with abdominal pain, they would not need an ECG. So this is, again, a tool that has become kind of popular that I've shared with people. And you guys anybody is welcome to incorporate that to their toolkit or their plan in their facility. This also would apply FMS in the field, also trying to decide who needs an ECG. With that, in summary, this plan hopefully will be helpful, better patient experience for patients, as well as making our emergency room physicians happier sending these folks home. Their adherence may not be 100%, and that's okay. I mean, it's really their judgment. But if they want to use a standardized plan, doing this with the heart score and a shared decision tool is probably the best plan available. So with that, thank you for your time, and I'm going to try and hand this off to Mindy to run the show for Dr. Marcel. So thank you.
Thank you so much, Richard. All right, next up we have Dr. Scott Mikesell. He's going to cover the non-STEMI and STEMI guidelines and then talk about a few patient cases to illustrate that care. I'm going to switch over this here and I should be able to. Scott, ready?
I'm ready. Welcome. So I'm going to go on and further what Richard just talked about, and specifically in relation to the STEMI and non-STEMI guidelines. We're going to talk a little bit about specific patient examples and how these algorithms assist us in our evaluation. You can go on. So the algorithm of our sort of non-STEMI guidelines, and specifically we are targeting the patient population with elevated heart scores, so the high-risk population, as well as potentially with ECG changes or other identifiers of a non-STEMI. We obviously recommend admission to either CCU or cardiac-specific floor with cardiology consultation as able. Medications that we typically recommend are pretty standard, with aspirin, ticagrelor being the preferred P2Y12 inhibitor, or clopidogrel depending on availability, as well as sensitivity, and then prasugrel or FEN in occasional circumstances. Standard heparin dosing is advised. And then assessing for whether the patient needs to go to the cath lab or not. Generally, an early invasive strategy is preferred over delayed, and certainly relative to therapy for a non-STEMI. Therapy for a non-STEMI is appropriate, but generally the outcomes have far consistently been side of an early invasive revascularization strategy, whether that be via CABG or PCI. The ischemic guided medical strategy, which is on the right hand of the slide, is generally very similar to what the initial medications, with the addition of an ACE inhibitor or an ARB, beta blocker, and statin, with referral for cardiac rehab. Reassessment for possible coronary angiography and revascularization can be made at that time as well. You can go live. So your chart, once again, very similar to what we just discussed. The thing to highlight is down at the bottom right, that didn't necessarily cover, but is the late hospital or pre-hospital care. And the most important thing that we tend to forget in total, whether it be a non-PCI or a PCI center, is the referral to cardiac rehab. Not unlike what Richard said as far as EPIC and other EMRs, this can be a built-in order for all of these patients depending on the protocol that we are following. Go ahead. So the case study in a non-STEMI that I recently evaluated, she's a 36-year-old female with uncontrolled diabetes, hyperlipidemia, and tobacco abuse. She had 3 weeks of epigastric discomfort that her primary and other urgent care physicians thought was most likely to be gastrointestinal in origin. In fact, she was set up for an EGD. She developed a particularly severe episode after smoking, and that was kind of a trigger for her. She noticed that her symptoms primarily occurred smoking or with some exertion or walking out in the cold air. And night after smoking a cigarette, the discomfort would not go away, and it would radiate from her epigastrum up into her chest. It may or may not have been associated with shortness of breath. She wasn't certain. It hurt to breathe. She went to her local emergency department, which was a non-PCI center, and serum troponin was detectable, so it was in that middle range on the heart score. So if you calculate her heart score, it's anywhere from 4 to 6, so she sits in that middle range. She was transferred to our center for further workup, where her serum troponin was noted to be markedly elevated, which then placed her by heart score we place in the high-risk population. So next slide. So this is G, and it's frankly completely unremarkable, and those consistent across the referral and then our receiving center as well. So click on the first slide. This is her, and this is a kind of an AP caudal view of the heart. So on the top of this, what you're seeing is the left main coronary artery extending into the left anterior descending artery, and then dropping down below is actually a circumflex artery with a branch, a large branch called the first obtuse marginal. And right at the beginning of that branch is a very, very discrete, tight of both probably atheroma plus thrombus. She did have other moderate atherosclerosis, specifically in her mid-LAD, which you kind of get an idea of there, as well as in her RCA, which I don't show here. The picture is after her stent. It should look like. And so remember, this is a luminogram, so the stent really, I mean, you can see it, but what if you compare the two pictures, what you can see is that the pinch or the significant narrowing in the beginning of that vessel is gone, and she's a new owner of a stent. And what we have to remember in this scenario is that the stent fixes the plumbing; it doesn't fix the disease. And so the medical therapy for a person with a non-STEMI that goes down the invasive pathway is identical to the actual non-invasive pathway as well, because not only are we treating the plumbing problem, we're also treating the cause of the plumbing problem, i.e. atherosclerosis and subsequent plaque rupture. So to transition into the STEMI systems of care, you'll see a lot of these topics are somewhat related with the medical therapies and the diagnostics being similar, and time is of the issue. Now, in STEMI care, we all know that patients as soon as possible is of the essence given the acute mortality that's associated with this. Certainly over the last 10 to 20 years, these systems of care have improved outcomes for these patients markedly, and even in my career in the last 10 years in Duluth, we've seen this as well. Opportunities that have been identified to improve these systems is generally, and this is kind of the bastion that we've lived in, is the pre-hospital cath lab activation and identification of a STEMI, having protocols in place to do so. This led to 911 EMS destination protocols, whether we, frankly, in the old days, whether ambulance would stop at a non-PCI center for further diagnostics, and then eventual transition to a PCI center, whether it would be more efficient, especially in a rural setting, to bypass the non-PCI center to go on to a PCI center and actually lead to a faster door-to-balloon time. And then to drill in the door-in, door-out at a referring hospital to ensure that if there's a stop on the way that it's as possible. And with this, developing transfer PCI protocols and then developing feedback loops. Patient level and family level, public level education on what the signs and symptoms of the onset of an MI would be. We can go to the next slide. So, a map with a lot of circles and whatnot, and the small red circles are all of the centers in the state of Minnesota. So Bemidji, Grand Forks, Sioux Falls, Mankato, Winona, or Rochester, and then the St. Paul area, St. Cloud, and then City, Wisconsin, including Eau Claire, La Crosse. We can move on. Yeah. Here's our STEMI guideline, which we spent many years developing. It's pretty much lived in this form since about 2016. the application of the STEMI is predicated on a threefold system, whether that be in the field, which is what is the preferred model, where the patient or family member activates 911 and a 12 ECG is performed in the field, and then the decision to transport is made depending on the transport time, bypassing the non-PCI center. If the first medical contact to PCI is thought to be less than 120 minutes, PCI is preferred. If the estimated first medical contact to PCI is greater than 120 minutes, then the recommendation is to pursue a thrombolysis. That is in the yellow box. The box is a alternative strategy where thrombolysis is used in conjunction for PCI for patients that the first medical contact to PCI time is estimated to be somewhere between 120 and 180 minutes. A few in the state of Minnesota use this protocol. Not everybody does. And once a STEMI has been identified, the recommendation is to activate the COAT STEMI system and the cath lab at the institution of destination. Transport the patient. So caveats to this, injection care priorities, and this is important especially for the cath lab, is our resuscitation status must be established. There's a lot of debate amongst interventionists and emergency providers whether this is actually important or not. But the ability to resuscitate a patient in the cath lab is a prerequisite to go to the cath lab. And so that is a very important thing. Other identifiers of potential STEMI that can come up is left bundle branch block in particular. The recommendation in that scenario is to transport to the nearest center to figure out whether this is truly an acute coronary syndrome or not. Okay, we can move on. With the STEMI line, on the second page is the contraindications, absolute and relative to fibrinolysis, the dosing of tenecteplase, and then on the right-hand side are all the primary PCI centers for STEMI with their phone numbers for reference. So the lines, this is our effort to standardize and protocolize the actual evaluation of these patients to ensure timeliness of identification of these STEMI patients. So in the first box, we talk about obtaining a 12-lead ECG and initial assessment of the biosigns, which is standard. We also talk about generally the patients that warrant a 12 ECG, chest pain, pressure, tightness, obvious heartburn or epigastric pain. This is an important one. It's called heartburn for a reason. It's because the human brain doesn't have the fidelity to figure out whether actually this is the stomach or the heart at all. The nerve endings in the chest and the epigastrium nearly as sensitive as, say, your fingertip, and so a number of patients can present any number of ways. And what we're getting at is that a 12 ECG is not an invasive procedure and easy to do when in the right hands. And so figuring this out and doing a pre-hospital ECG can save a life and actually leads to much improved outcomes in the long term. Subsequent to identifying a STEMI, activate the system per the protocol, and determine the transport destination, whether that be a referral center or a primary PCI receiving center. And so generally what we talk about is if the transport time is less than or equal to 60 minutes to a PCI center. If the transport time to a PCI center would be greater than 60 minutes, then transport to a referral center, and then decide whether thrombolysis will be necessary or not. We do list some diversion criteria, generally for possibility of stroke or neurologic compromise, circulatory instability or shock, chest trauma, DNR status, and left bundle branch block come up here. So BLS, ALS, and then if available, consider medication. Some MS providers do provide and potentially dual antiplatelet therapy. This is not universal across the state of Minnesota, but the systems that do are well known to generally the PCI receiving centers, and this is part of ongoing investigation research, whether this is truly beneficial or not. Only from my point of view, if it really is a STEMI, the earlier the dual antiplatelet therapy gets administered, the better. Okay. This is algorithm. I'm not going to go through the whole thing because generally it's the diagram that is some recreation of what we've already gone over here, but it's there for your reference. Go ahead. How did we do this in Duluth? Everything is very similar to what you've seen previously outside of that middle box for the estimated aorta balloon of 120 to 180. We do not have in our algorithm here in Duluth. Essentia and our Institute of St. Luke's have done a more standard approach with primary PI with estimated first medical contact to PCI of less than 120 or greater than 120. And then thrombolysis, and we are in thrombolysis or fibrinolysis season right now with the winter, and so we are taking phone calls as far as are we going to be able to transport the patient within that period of time. Tenecteplase being the drug of choice with the dosing regimen on the, again, on the second page. And then with patients that are 65 years or older, we use a half-dose protocol with 75 milligrams of Plavix, and then determine once they arrive at the PCI receiving center whether they should go on to coronary angiography and PCI emergently or in 24 hours, generally. Case scenario, so we have an 84-year-old female with a month of stuttering, intermittent chest pressure, and mild exertion. This significantly worsened over when she was watching television, and suddenly EMS was activated. To the ECG from the field, and this is what we typically will get. It's a printed out strip. And in this ECG, we have actually pretty profound interseptal ST elevations, V1, V2, V3, which is rated by the ECG that was performed in the hospital upon arrival. The cath lab had been activated, so this is the initial angiogram. Areocranial picture of the heart, so this is looking for the right shoulder down, and what you're looking at the top of the picture is the left bay-cardiac artery. And the anterior descending artery is what's missing in the middle portion of the picture, and there's kind of this skip area. There's this empty space. That's the LAD. That's the thrombus, the occluding. And then at the apex of the heart, the very bottom at the end of the picture, you can get a feel of the end of the LAD. Side for reference, that's the left circumflex artery. So this is a different way of looking at the heart than the angiogram we had shown previously. So this is a cranial view, so this is left shoulder down. It's a different view of the LAD, but the LAD will run straight down the middle of the picture, and you can see that skip area and just the whole vessel generally being, or just not present. Cranial view. This is after PCI and stent placement. And so now, if you compare, you can see the stent at the beginning of the shot before the contrast goes through. And you can see how the artery is now complete patent and with normal flow to the apex, which you want. Residual ECG with some mild residual ST elevations. Biphasic T waves. These biphasic T waves are normal and generally an acceptable transit ECG over time. It did not demonstrate recurrent ischemia. This is important, and there are several references for the evolution of ECG changes after a STEMI, which are easily findable via Google. But this is important to know that a little bit of residual ST elevation with biphasic T waves are actually normal findings in a person who has had an acute transmural STEMI. Next one. Okay, so now I'm going to hand back to Mindy and Jim.
Thanks, Mike. So, are you on the line?
Exclaims, you may please press star 0 for an operator assistance.
So John, just press star 0 and we'll place you into the speaker room if you're able to do that. Our date is on the Minnesota Cardiac Systems of Care from the Department of Health. We'll just give a second to join. He's going to talk about the development and their support of the Acute Coronary Syndrome Chest Pain Toolkit and their program for STEMI Receiving Center designation. Jim, able to be heard?
Hi now.
Thank you.
Okay, sorry about being a little bit late, guys. I just wanted to give a brief overview of things going on here at the Minnesota Department of Health and remind folks that in 2016, the legislature granted the Department of Health the authority to designate hospitals as STEMI receiving centers, Minnesota Statute 144.491. And I congratulate 4 hospitals in Minnesota or on the borders, the 2 in Duluth, both St. Mary's and St. Luke's, in Fargo, and Sanford and Sioux Falls, going through the designation process with the state. And Scott talked earlier today, the ACS toolkit that's been described, and we are working to get this into an accessible format, and we're hosting that here on the Minnesota Department of website early in 2019. We'll let you know when that happens. But the page that you see now is the existing page that we have here at the Department of Health around STEMI systems of care and the hospital designation process. Statutory language is linked up there in the top right if you're interested in reading that. I give everyone a caution, even though we provided a link here at the bottom of this page where you can directly find this website, sites are going through a major overhaul through 2019, and the link will probably become inactive sometime in February. Never fear, you can just go straight to the Health Department website, health.state.mn.us, type me in the top right corner in the search box, and it will take you to the correct page, even when that changes. Next slide. The application is directly linked from the page that we were just looking at. Here's another link to that application. And what I recommend for folks is before you decide to go forward with being designated as a STEMI receiving facility by the state of Minnesota, is that please contact us first to ensure that whatever program you're choosing meets Minnesota's standards for STEMI receiving facility. This is a rapidly evolving space for a number of different certification bodies, including AHA, the Joint Commission, ACC, and so on. And we make sure that you don't start down a path which requires a lot of time, resources, and money if that wouldn't meet the state standard. Joint Commission and AHA have been working on a Joint Comprehensive Cardiac Center certification. We've not yet reviewed that internally here at the Health Department to be sure that that meets Minnesota's standard, although I'm confident it will. So again, I just would advise you, if you're going to go down a certification route at your facility, make that you contact us first so that we can verify that what you've chosen will meet Minnesota state standards. You can apply for the receiving center designation at any time. I will be reviewing the emails as they come in here, and we will follow up with any questions that we have on an application within 1 week of it being submitted. We'll review those immediately, and we plan on, and we have been issuing certificates on a monthly basis. The STEMI Receiving Center designations that we issue here from the Department of Health are in place for the same period of time that the official certification is by the approved national recognized certification body, that be AHA, Joint Commission, ACC, or whoever that may be. So I think that is when I transition it back to you, Mindy.
Thanks, Jim. All right, so we'll things up with my updates. I'm Mindy from the American Heart Association. I'm going to go about our Get With the Guidelines CAD registry, which is our data source for reporting to mission line that powers our regional reports and quality improvement efforts. And then I'll just go through a few top opportunities and top performance measures in both the non-STEMI and STEMI populations from my Get With the Guidelines CAD registry. So this is a relatively new registry for us. We transitioned to our own registry for coronary artery disease just about 1.5 years ago. And this allows us to collect information on both the non-STEMI and STEMI populations at this point. in the future, we will start collecting low-risk chest pain population, which is useful as we look to age hospitals to improve all means of cardiac care that they take care of in areas. Mission in Minnesota has been a program for the past 5 years, the first 3 years of which were a STEMI grant-funded initiative where we were able to equip many of the EMS agencies across the state, about 120 of them, with 12 lead ECG pre-hospital equipment, and then hospitals across the state with the receiving equipment to in that communication, pre-hospital notification recognition of STEMI patients. So that effort was supported by our quality improvement staff like myself, and we focus really on making sure that where it is in Minnesota doesn't determine if you live, and wanting to standardize that process for timely reperfusion. I'm excited to see these efforts expand beyond STEMI this past year with the low-risk chest pain recommendations we've been able to make and the non-STEMI recommendation. So we're going to offer improvements and bring together partners from across the state to standardize these efforts. In Lifeline programs, we do have a recognition opportunity in both the STEMI and non-STEMI patient populations. Recognition measures are listed for you here for 2019. These measures had not changed significantly for us in the past years. I'm going to talk about how they will change in 2020 in the next couple slides, but most of you should be familiar with these measures as you've worked with Mission Lifeline throughout the past several years. In this STEMI group, there are achievement measures for both the receiving hospitals with PCI capability and those without PCI capability, the referring hospitals. And these measures largely relate to the system of care starting at the first point of medical contact in the EMS agencies, when that is the first point, through referring hospitals that do have a PCI capability and PCI centers. So there are time recommendations for those therapies from EMS and the referring centers from door in and door out. And then when patients do arrive, there are inpatient and discharge therapies that are recommended there on the left-hand side. In the population, we have 5 achievement measures. These relate to both referring and receiving centers, so either level of centers that are treating non-STEMI patients. And these are a little bit different. They are not time-related at this point. They're inpatient treatment and then discharge therapies that should be recommended, including cardiac rehab and dual antiplatelet therapy. How this process works is you have to meet the measures listed here for a period of time, and that period of time determines what level of recognition you receive. So bronze is 1 quarter, silver is 1 year, gold is 2 years. Achievement thresholds are listed in each form. In 2017, the ACC and AHA came together to recommend a expanded group of ACS metrics. At that time, they did retire a few of the metrics that we had been monitoring and make new recommendations. So it has not been a change that both bodies do recommend that all hospitals participate in a regional or national registry and engage in quality improvement efforts around this population. They did the excessive heparin dosing measure, eliminated counseling for smoking cessation just because the adherence to that has been near 100% for several years, and so retired to a reporting measure. They also retire monitoring of the LDL level and high-intensity statin therapy for all patients with acute MI. And then also recommended evaluation of left ventricular ejection fraction as opposed to systolic function. Further recommended a P2Y12 inhibitor at discharge rather than just previous terminology, which was for critical only, now that we have a couple of new medications in that class. The metrics included risk stratification for non-STEMI patients, an early invasive treatment strategy for high-risk non-STEMI, like we have put together in the consensus-based tool kit for non-STEMI patients that we were today, therapeutic hypothermia for coma-STEMI patients with ROSC after out-of-hospital arrest, aldosterone antagonist to discharge for those with a reduced ejection fraction, avoiding non-steroidal anti-inflammatories, Avosagril in patients with a history of stroke or TA. There were originally 3 black box warnings regarding that medication, so there was an expansion of those warnings, and then avoiding high-dose aspirin with ticagrelor in combination at discharge. So the AHA Mission Lifeline Receiving Center recognition measures are going to be modified slightly here, and this is a summary of what those changes will be. So aspirin on arrival is one that has been highly adhered to for several years, so that will be moved to a reporting measure, as well as smoking cessation. This next year, we will have arrival to 12-lead ECG within 10 minutes, where patients walk directly into an emergency department seeking care, and cardiac rehab referral for the STEMI population. That had been an achievement measure just in the non-STEMI group. Advantages will be a recommendation for a high-intensity statin at discharge, and time first medical contact to primary PI at a receiving center for patients being transferred remains at 120 minutes. However, it will be moving to a reporting measure in 2020. Hospital groups, so these are hospitals that do have cath labs. The recommendations that had been made are not changing for the time metrics. However, there are a few new measures that will be in this population. The achievement measures are remaining the same. We're adding a new plus measure. So this is on top of the bronze, silver, gold. You can achieve a plus level award if your door in, door out time is less than 30 minutes, trying to encourage the quick patient turnaround time in the emergency department. The reporting measure for patients that are treated within those hospitals and not transferred out, that they receive cardiac rehab referral and high-intensity statin therapy at discharge. In the non-STEMI population in 2020, we also have a few changes. In the cardiac referral, there'll be additional exclusions offered. So if the patient has a medical or a health system-related reason for not being able to comply with that therapy or it not being appropriate, there are exclusions available there. And the level to 12-lead within 10 minutes and then high-intensity statin at discharge measure will also be added to the non-STEMI population. So we're seeing more parity there. So with the guidelines CAD registry, I'm going to talk a little bit about our day in Minnesota, but just so you have an idea of participation across the Midwest, you can see we have just under 80 hospitals, and that may have changed from the time I put together this slide. In our 11 state affiliates, 5 in the state borders of Minnesota, and 7 participating in our regional data work in Minnesota. And those include a few of our border facilities. So when we look at our top performing measures in Minnesota, we've done a great job and have worked a long time on our STEMI treatment across the state and really kind of hardwired these processes to a point where we're seeing very high achieved in our primary PCI within 90 minutes for patients walking into our facility. We've been over 95% adherent to this, consistent for the several years. Statin at discharge, which is changing slightly this year, but you can see for the past year of reporting, we've met that measure at near to 100% as well. So congratulations to our participants. In the STEMI population, the things that we're doing well are our cardiac rehab referral from the inpatient setting and the dual antiplatelet therapy prescribed at discharge. And I want to draw your attention to this one specifically because the national for adherence recommended for the dual antiplatelet therapy is 65% adherent, and you can see here that our hospitals in Minnesota are meeting this at, for the 90th percentile in aggregate over the last year and the last 2 quarters at 100%. So this is excellent their delivery of the dual antiplatelet therapy for those non-STEMI patients. Our top opportunities remain those metrics that involve collaboration and transitions of care. So our Mission Lifeline EMS first medical contact to PCI within 9 minutes for those without an extended transport time, within 120 minutes for those with an extended transport time, remains somewhat of a challenge, and you see the adherence a bit over the last year. We are about 80% over the past year and a half compliant to that measure in aggregate, but we'd really like to see a little higher that for those patients who are calling with their first sign of chest pain. Measure listed here is our request measure. This relates to patients being transferred between facilities, so they arrive at a center that doesn't have a cath lab first and then are transferred for PCI with the expectation of that delivery happening for them within 120 minutes from the first facility. In some of the areas of the state, and that is why we have a mixed strategy with the LICIS opportunity for those patients that can achieve that with 120 minutes time frame. But you can see here across the last year or so, we do have some fluctuation. We're below 80% adherent in all of these cohorts, and I think we do need to look at this population to see if there would be an opportunity for some of these patients to receive lysis prior to transfer, if that would be in their interest. Lower numbers across each of the quarters. We have as many patients being transferred between facilities, so we do see a bit more fluctuation between the quarters. But these two remain our opportunities for improvement and collaboration across the state of Minnesota. Yes, we can open the lines for questions. I did want to say is for any of you who are interested in the toolkit from today's presentation, we will send that out to all of you after the call who participated today.
You'll now begin the question and answer session over the phone. Participants, you may please press star followed by the number 1 to ask a question. And please unmute your phone and record your name clearly when prompted. Your name required to introduce your question. And to cancel your request, you may please press star followed by the number 2. Once again, participants, to ask a question, that is star followed by the number 1. In 1 moment, speakers wait for first question over the phone. One participants over the phone to ask a question, that is star followed by the number 1, and you'll be prompted to record your name. And cancel your request, you may please press star followed by the number 2. And 1 speakers wait for first question over the phone. And at time, speakers, we don't have any questions in queue. You may proceed.
Great. We close the call then if we have no questions today. And I thank everybody for joining. Hope you have a wonderful rest of your day.
And that concludes today's conference. Thank you for participating. You may now disconnect.